So I'm just going to give really an introduction to this next two speakers about immunotherapy background in general, immunotherapy in ovarian cancer and the completed and some of the current trials, and then future directions in ovarian cancer immuno-oncology. So immunotherapy has been around, or the concept of the immune system or inflammation and cancer has been around for a very long time. Rudolf Virchow first described the infiltration of tumors by leukocytes more than 150 years ago now. And it wasn't long after that when the first immunotherapy was ever used, a very crude immunotherapy called these toxin that injected streptococcal toxins around soft tissue sarcomas, leading to responses in many patients, but also a high incidence of infection and sepsis. Fast forward to the modern understanding of the immune system and how the body responds to self versus non-self, and the first description of this model was by Frank Burnett. But our understanding of the immune response to cancer has evolved further since then, and a simplified way of looking at the CD8-mediated anti-tumor immune response can be divided into 6 steps, but it can be 6 or 7 depending on how you break it down. Initially, you need tumor cells, obviously. You need antigen to be presented, and the release of that antigen may occur either spontaneously or as a response to treatment intervention, which may be chemotherapy, radiotherapy, or targeted therapies. Those antigens need to be presented to professional antigen-presenting cells. The best of those is dendritic cells, which then traffic these to the draining lymph node, present them to naive T cells, and then the next step is over and above the antigen presentation, we need confirmation of the signal, so signal 2, and the balance of really stimulatory and inhibitory signals to ultimately result in T cell priming. The CD8 T cells must then proliferate. They will need to traffic again back into the tumor microenvironment and result in cytotoxic cell death, overcoming any local resistance mechanisms that prevent this from occurring. And then after that, to develop long-term immunity and rejection of relapsed tumor, we need to generate memory T cells. That is probably contributing to what's leading to the durable responses that we see from immunotherapy. And this is when it all started, the modern checkpoint inhibitor era, with the first study in melanoma that led to the registration of the first checkpoint inhibitor, ipilimumab, without a very impressive response rate. It was only 10.5% rate in that first study. But the very important finding in that was that tail of the curve, was that patients that responded tend to respond for extended periods of time. And when these were extended and pooled data from many of the early studies and pooled studies of first-line ipilimumab or combined studies that had ipilimumab in a recurrent setting, these durable responses go out to 10 years in the longest follow-ups. And at 3 years, at 36-month mark, is where there's an inflection point in the curve where it turns from patients dying continuously until when it flattens. If people survive after 3 years of being treated with ipilimumab, most of these patients were still alive 10 years later. So FDA-approved indications of immuno-oncology agents. The first was melanoma, ipilimumab. It took a few years before the next registration, and that was pembrolizumab, a PD-1 inhibitor in melanoma. But after that, it came thick and fast in melanoma, other PD-1 inhibitors, combination immunotherapies in lung, bladder, renal, classic Hodgkin lymphoma, head and neck, and the list is growing, including the first tumor-agnostic registration for MSI-high cancers for pembrolizumab last year. Of these are the drugs that are approved in Australia, only in melanoma, lung, and renal cell cancer at this stage. But there's a number of others that are TGA approved and awaiting consideration for funding. Of these, the only gynaecological cancer approved indication by the FDA is MSI-high cancers, which would be endometrial cancer in that setting. So in ovarian cancer, as alluded to earlier, we've known for quite a long time that T cells, intratumor T cells, are important prognostic markers, and they can predict significant improvements in survival in those with infiltrating T cells compared to those without. This is now 15 years old, and similar data is seen in other tumor types. So despite the fact that ovarian cancer sits fairly leftwards on that neoantigen or mutational burden spectrum, when there is T cell infiltration, outcomes can be significantly improved. So it is really this group, and if recurrent ovarian cancer is not highly responsive to immunotherapy, what we really need to identify is either patients that do have this endogenous immune response, or if it's not there, what we need to induce that response to try and improve those response rates. So the reported trials, the first of these was actually not of checkpoint inhibitors, but adoptive cell therapy quite some time ago. I think that goes back to 1995. And that was just a single cohort, small study that still showed that the disease-free survival is 82% compared to kind of a matched control that had an expected 3-year survival of 54%. But in contemporary data for the PD-1 inhibitor nivolumab, and really across that column, we can see that response rates are modest, 10% at best, 22%. And in that atezolizumab study, breaking down responses by number of prior therapies really started to give us an indication that lesser line of therapies had a higher response rate compared to those with greater number of prior therapies. And I should add probably to that the study that Linda mentioned earlier today, which is combining a PARP inhibitor and a PD-1 inhibitor, and that had a response rate of 26% in pre-treated patients in a small subgroup, which was 34 patients on the trial. And also, as mentioned, when there is a response, this is what we're after. If there is a response, it can be durable. So with a small number of patients that responded, many of these responded went out to beyond a year, including complete responses that remained durable. In recurrent ovarian cancer, this is probably only a small selection of the studies that are now ongoing, and there's new announced almost on a fairly regular basis. But combinations of either different immunotherapies together, so there is a nivolumab plus or minus ipilimumab, combination of chemotherapy, typically with immunotherapy, with or without bevacizumab, as well as incorporating PARP inhibitors into that treatment paradigm. So several phase 3 studies totaling almost 2,000 patients looking at the role of immunotherapy, typically in combination in recurrent ovarian cancer. In newly diagnosed ovarian cancer, there are a number of studies. This is the most important of them, which we'll talk about a bit in the end. So iPrime is a phase 2 study looking at first-line chemotherapy given in the adjuvant setting with or without durvalumab and tremelimumab. It is really still a non-comparative. It's randomized, but it's non-comparative study looking at this combination and using chemotherapy response as an endpoint, but we'll come back to that later. And then there's a few other studies that also look at frontline chemotherapy with or without immunotherapy. Probably one of these is completed, Javelin 100, and we're waiting results. The atezolizumab study, I think, is ongoing and probably approaching accrual, and then several other studies that are either commenced or about to commence over the next few months. And you can see that several of these now are incorporating not only chemoimmunotherapy, but also the addition of PARP inhibitors to this patient population, typically as a switch maintenance approach after finishing these 6 cycles of chemotherapy. So I need to go back to the immune cycle, to those 6 steps of immune response, and try and break it down into how is it, what are the different theories of we may be able to enhance the immune response when it is not completed, when it is not occurring successfully. Because what we're trying to achieve is elimination or at least equilibrium. So the very old immune surveillance theory that there is a balance of anti-tumor immunity in a lot of cancers, but when that fails, you have tumor escape. When that is highly successful, there's the elimination, but also equilibrium. We know that after 16, 20 years of having an early melanoma removed, patients that donate their kidneys the recipient has developed, following immunosuppression, metastatic melanoma, despite the donor living their whole life with melanoma and never suffering a recurrence. So we know that a lot of patients will live decades in that state of equilibrium without ever detecting a recurrence. And that probably happens in other cancers too. So all these steps are required to achieve an immune response, certainly at least to achieve an initial immune response, but for durability we also need immunological memory. Different tumor types will need either different... We've kind of picked the low-hanging fruit. We've picked the tumors that have a high endogenous immune response or effective endogenous immune response, and they just need that extra little push to achieve a response. But for other tumor types, we're going to have to identify what is missing, and if possible, how we can address it. Biomarkers, which I'll just touch on, really are again not easy in checkpoint inhibitors. We have a number of biomarkers, but they can be dynamic. They can change. So, like acquired resistance to other therapies, there can be a change in PD-L1 expression after initiation of any treatment, whether it's in immunotherapy or even chemotherapy. So if we look at the first section, how can we help antigen release in tumors that don't have antigen release, these cold tumor microenvironments? Can we enhance that by enhancing killing and release of antigen, whether it's by chemotherapy or targeted therapy or even radiotherapy? Whether we need to actually provide directly either DC-based vaccines or vaccines from that particular tumor type to enhance that initial antigen presentation. Overlapping a bit with presentation and priming, where checkpoint inhibitors can come in. Improving T-cell priming is thought to be one of the ways CTLA-4 inhibitors work, but also it enhances Treg or reduces differentiation into Tregs. How we use single versus combination immunotherapy. PD-1 inhibitor tend to work a bit later on in immune cycles, whereas other immunotherapy agents, when they help that co-stimulation section, may help with that earlier priming part. Harnessing immunogenic DNA-damaging agents, whether it's cytotoxics or PARP inhibitors, and looking at other co-stimulatory molecules or co-inhibitory molecules that need to be blocked through combination strategies. And at the moment, PD-1 backbone combination immunotherapies, and I think George is going to talk a bit more about that, are forming a lot of the current trial designs across a wide range of cancers. Trafficking trafficking tumor infiltration is important as well. PD-L1 upregulation on some tumor types is one of the barriers. You have antigen, you have generated T cells. The T cells perhaps manage to infiltrate, but when they penetrate the tumor microenvironment, PD-L1 expression, perhaps on tumors, perhaps on immune cells, can cause T cell anergy and tolerance and prevent an effective immune response. Perhaps if we can't, we just need to generate these T cells exogenously altogether and create tumor-specific T cells that are then injected. So if we are unable to achieve effective T cell proliferation through the initial steps. How can you address the other barriers like tumor-associated macrophages and fibroblasts, and also looking at the tumor microenvironment-specific inhibitory factors like the upregulation of IDO and LAG3, which sometimes can occur as adaptive resistance mechanisms once a PD-1 or PD-L1 inhibitor is initiated. Memory is difficult. We still don't have specific kind of drugs that target or improve the generation of memory T cells. But there is probably some data to suggest that even old immunological data that says you generate memory T cells better when there is no chronic exposure to antigen. So that might play into the fact that the greater tumor burden, the harder it is to achieve good immunological responses or durable responses, but also that complete removal of a tumor by whatever means, whether it's surgical or ideally with drug therapy, will enhance the generation of memory T cells, but also other targets that may help modulate or skew the T cells to generating memory T cells as well. So I'm not going to go too much of that, but this is just really quite an old slide that includes many of the other co-stimulatory inhibitory molecules that are now partners with PD-1 or partners with each other in various stages of development. So, biomarkers is really the next point I wanted to touch on. There's a lot of trials ongoing. Unfortunately, several large phase 3 studies, including a novel combination of PD-1 inhibition and IDO inhibition that was negative, was announced as negative at AACR a few weeks ago. So we need the trials. We need to identify the biomarkers. When small subsets of patients benefit, we need to try and identify those patients. I'm going to skip on that. So just again touching a list on some of the biomarkers, but this is really a separate talk. PD-1, PD-L1 expression seems to be really tumor type specific. It seems to be more important in lung cancer than it is in melanoma. It is a dynamic biomarker. Time of biopsy, whether it's more than 6 months ago or is it fresh, is it before or after initiation of treatment, tracking it over time, the assay methods, there's a lot of work to be done, but a single biomarker like that is unlikely to be sufficient across all tumor types and across all settings. Mutational burden, new antigen burden, tumor infiltration lymphocytes, mismatch repair deficiency or HR deficiency, and other immune signatures that are increasingly being reported as correlates for some of the ongoing trials. Hopefully, a combination of these will inform us a bit better about which patients should be getting single agent, doublets, and what combinations will be required. So I'd like to spend the last 3.5 minutes just giving an overview of iPrime, which is an ANSGOG study. It's an investigator-initiated study examining the addition of two immune checkpoint inhibitors, durvalumab and tremelimumab, in combination with neoadjuvant carboplatin paclitaxel in newly diagnosed women with advanced ovarian cancer. This is a 2-arm study. It's randomized, but it's non-comparative. So the endpoint is really looking at the pathological response in the intervention arm. Historical data for for chemotherapy response score shows that we expect about 30% complete response, which is the CRS-3, and we are aiming to achieve a CRS score of 50%. And some of that design really almost came from I-SPY 2 that Peter talked about, in that triple-negative breast cancer patient population treated with neoadjuvant paclitaxel added to pembrolizumab, that tripled the complete pathological response. In a population of patients that even de novo response rates are still fairly modest. We have 10 sites in Australia, which are listed here, 2 in WA, 4 in New South Wales, and then Victoria and Queensland. The ethics approval came through for 7 of these sites so far, and we're hoping that the first sites will be activated in the next few weeks. This is the study schema. So again, previously untreated stage 3 or 4 women with high-grade serous ovarian cancer, because this is the group of patients where a CRS score is predictive of long-term outcome, will be randomized to either the 4-drug combination or chemotherapy alone. And after 3 cycles at interval debulking surgery, the CRS or chemotherapy response score will be evaluated. Those achieving a complete response will continue on with the same regimen for a total of 6 cycles of chemotherapy. Those that do not have a minimal response or no response will discontinue treatment and be treated as per study physician's preference. And CRS2 with a partial response, there will be an option to either continue with the same treatment or discontinue if the clinician feels that they're not benefiting, or they would like to add, for example, bevacizumab if this is a stage 4 or stage 3 patient, or stage 3C suboptimal debulk patient. After the 6 cycles of chemotherapy, patients would continue with maintenance durvalumab and tremelimumab for a total of 12 months from starting treatment. So the primary objective is looking at CRS rate in the intervention arm after 3 cycles of chemotherapy. Secondary endpoints will include the conventional PFS, endpoint and looking at subgroups, looking at CRS rate, comparing the two arms to each other, CA125 response, residual disease, and other conventional endpoints. There's a number of exploratory objectives, and this part of the study, translational I-Prime, is funded by the OASIS initiative, and that will try and look at immune correlates both in the tumor and in the blood before and after treatment, but also hopefully with some on-treatment biopsies too. So we've covered this bit. Hopefully first patient will start treatment either later this month or early June. So in summary, immunotherapy in ovarian cancer, are we there yet? Not quite, but we're getting there. No approvals at this stage, but hopefully, actually in cervical cancer at least, that will probably be approved in the next few weeks, but in ovarian cancer, hopefully next 2 to 3 years. Response rates are modest, but moving treatment to the earlier time frame using combinations will hopefully improve this. We need to identify the right patient, the right time, the right combination. We need to improve our biomarker development so we can better pick the optimal treatment for our patients. That's all I've got.